We're speaking with Dawn Picotte, MD, about mood disorders, including depression and bipolar disorder, in children and adolescents. Dr. Picotte is Associate Medical Director of Child and Adolescent Services at Butler Hospital and a Clinical Assistant Professor of Psychiatry and Human Behavior at the Alpert Medical School of Brown University. Dr. Picotte, thank you for taking the time to get together with us.
It's my pleasure to be here, Jim.
Can you tell us about mood disorders, and particularly those that affect children and adolescents?
Yes. Mood disorders are a group of illnesses that include major depressive disorder, bipolar disorder, and some other variations of depression and mania. Major depressive disorder can occur in about 3% of children and up to 8% of adolescents. However, between the ages of 15 to 18, depression can occur in 14 to 15% of adolescents, which is comparable to that of adults. Bipolar disorder occurs in about 1% of adolescents, again similar to adults. Bipolar disorder is less commonly diagnosed in children compared to adolescents and adults.
So if a child has a mood disorder, what might be the most typical symptoms that they would exhibit?
A child with depression may feel very sad or irritable, may experience changes in sleep and appetite, may feel guilty or worthless, lack enjoyment in preferred activities, lack energy, and even think about death or suicide. He or she may become more withdrawn or experience crying spells. Youth with bipolar disorder may have depressive episodes characterized by those symptoms of depression, interspersed with manic episodes where they may feel extremely happy or act very silly, talk more rapidly and loudly than usual, have excessive energy and decreased need for sleep, and may engage in more risk-taking behaviors. Rapidly changing moods and increased anger are commonly described in children and adolescents. In both depression and bipolar disorder, these symptoms would be present most of the day, most days, and would persist, sometimes for weeks, and often without easily identifiable causes. The symptoms commonly interfere with some aspect of functioning, such as life at school, with family, or socially.
Are self-harming behaviors typically associated with these sorts of illnesses?
Self-injurious behaviors are a symptom, not a disorder. Recent studies have found that 1/3 to 1/2 of adolescents in the United States have engaged in some type of non-suicidal self-injurious behavior. This can take the form of cutting, burning, punching walls to induce pain, ingesting toxic substances, and interfering with the healing of wounds. Most agree that self-injury has more to do with ineffective coping skills than anything else. Although distinctly different behaviors, many of these youths have also made suicide attempts at other times. According to one recent study, 70% of patients who hurt themselves had made at least one suicide attempt, and 55% had made multiple attempts. Some references indicate that the majority of people who self-injure are female teenagers and young adults, but others cite self-injury across the lifespan in both sexes. Most believe that self-injury is done to cope with overwhelming or disturbing situations, and people often describe a temporary release of their emotional pain as a result. Others have indicated an addictive quality to these behaviors. Stopping self-injurious behaviors such as cutting or burning usually requires acknowledging them as problematic, identifying triggers, and addressing the underlying feelings.
What are the most common types of treatment to help children affected by these disorders, and are some better than others?
Accurate diagnosis coupled with appropriate treatment can improve outcomes of mood disorders. Treatment for children and adolescents tends to be similar to that for adults, specifically combinations of medication and therapy, with a greater emphasis on family therapy and school consultation. Although many studies have proven the effectiveness of medication, most illnesses respond best to a combination treatment. Cognitive behavioral therapy is the type of therapy most proven to be effective. It teaches a child to challenge negative thoughts and manage difficult feelings. With all treatments for children with mood disorders, the goal is to reduce suffering and minimize the impact on normal development that should be occurring at that time.
In recent years, there's been some controversy in the media about whether or not bipolar disorder is being overdiagnosed in children. Could you talk a little bit about that?
You're right, Jim. Bipolar disorder continues to be controversial and difficult to accurately diagnose. As one study indicates, the increase may be due to recent tendency to overdiagnose bipolar disorder in young people, a correction of the historical underrecognition, an actual increased incidence, or a combination of these trends. Through studies, however, we are rapidly acquiring knowledge about the diagnosis, the course, and evidence-based treatment of these illnesses in children and adolescents that should improve our ability to diagnose and treat patients with these disorders in the future. These disorders present with an intensity of mood and persistence of mood that helps to distinguish them from just phases, but differentiating a mood disorder from adolescent moodiness can be difficult. A professional and systematic evaluation that looks at impairment at school, home, and socially is often useful. Symptoms can evolve over time, so repeating an assessment if symptoms worsen or don't resolve is also recommended.
So if someone suspects that their child is being affected by one of these disorders, what should they do?
Parents who suspect that their child may have symptoms of mental illness should speak to those who know their child well, including teachers, coaches, other trusted adults, and then seek professional help. Usually this begins with their pediatrician or primary care physician, who may make referrals to mental health providers. Parents can also call their insurance company directly for mental health referrals.